This is Blood and Cancer, the official podcast of MDedge Hematology/Oncology, where we discuss the latest research, treatment considerations, and other issues related to hematology and oncology.
Welcome to our podcast. You just heard the voice of your regular host, my colleague, Dr. David Henry. I'm Dr. Alan Lyss, and I am very pleased to be your guest host this week. Today, we're going to be speaking about advanced urothelial cancer. Now, you know and I know that like many other solid tumors, the systemic treatment options for urothelial cancer have really burgeoned lately. This past year, there were several studies presented and published that changed routine clinical practice for urothelial cancer and resulted in drug approvals by the FDA. And with us today to help us navigate the brave new world of advanced urothelial cancer is Dr. Arjun Balar. Dr. Balar is Director of Genitourinary Medical Oncology at NYU Langone Perlmutter Cancer Center and Associate Professor of Medicine at NYU Grossman School of Medicine. Dr. Balar, welcome, and thanks for speaking with us today.
My pleasure. Thanks for having me.
Let me start, Dr. Balar, by asking you for your perspective on what you see as the most important developments in systemic therapy for advanced urothelial cancer over the past several years. You know, the real practice-altering innovations.
So I think to answer that question, it's hard to answer it with just a single treatment paradigm or a single approach to therapy. I would say that it's really been kind of a deluge of different treatment approaches. It first began kind of in 2014, 2015, when the phase 1 experience with checkpoint antibodies, which have obviously revolutionized cancer care across solid tumors. When the phase 1 experience in advanced bladder cancer was first presented at the ASCO annual meeting, showing kind of rapid, durable responses in a subset of patients. Now, the initial data was probably kind of overestimated the benefit, 40 to 50% response rates, which is ultimately, came down to earth more in the kind of 20%, maybe 30% range, ultimately. But what was clearly evident is that bladder cancer is an immune responsive tumor. It's a carcinogen-induced tumor with a lot of neoantigens, much like lung cancer and melanoma. And quickly, we were off to the races with the number of trials, phase 1s, phase 2s, and phase 3s. And over the course of 2 to 3 years, we quickly incorporated PD-1 pathway inhibitors into our treatment armamentarium, first beginning with second-line therapy, demonstrating a survival benefit over the previous standard, which was single-agent chemotherapy after, which is essentially after platinum-based chemotherapy really had nothing effective and nothing that improved survival. And now suddenly we had something that improved survival. And then, we tested it in the first line setting in a group of patients that had long been ignored. Those are the patients with, poor medical conditions, advanced in age, poor predicted tolerability to the most aggressive therapies, including cisplatin, octogenarians, nonagenarians, those who wanted therapy but really couldn't tolerate aggressive chemotherapy. And suddenly immunotherapy was active in those patients as well, showing response rates in the 25 to 30% range and also durable complete responses in those patients as well. And so that, kind of shaped most of the 2016, 2017 area where we were super enthusiastic about immunotherapy. And I think our enthusiasm has tempered a bit since then. We're finding out that if we use chemotherapy in the right way in selected individuals, that probably is the better route for a lot of people. There still is a role for immunotherapy in the first line setting in selected people as well, but we're still teasing that out. And in the second line setting, it's still the standard of care. And now as we are looking at 2020 and 2021 and beyond, we're looking at a new class of therapies called antibody-drug conjugates and molecularly targeted agents. And I think antibody-drug conjugates are kind of the next generation where I see the field really transforming. ADCs are essentially homing molecules that target cancer-specific antigens that we can identify that are usually exclusively expressed on the surface of cancers and have limited expression on normal tissues. and allow us to more selectively deliver potent cytotoxics and to achieve more potent control of cancer, selective control of cancer, and provide the ability to treat patients for longer periods of time and achieve more durable control of cancer. And what we're also finding out is that you can pair these drugs extremely well with immunotherapy. And that's where I think the field is really headed, is combining ADCs with immunotherapy. And I think in the next 3 to 5 years, we're going to find ADCs plus immunotherapy become the new standard of care.
Let me drill down on that a little bit with you, if I may. As long as you bring up the ADCs and you bring up targeted therapy in general, before we get into the weeds of specific new agents, I know you practice at a major academic center, but in your view, does molecular testing play a role in standard practice in 2021 in patients with advanced urothelial cancer in refining how we use these newer agents?
It absolutely does, but what it requires, though, is a drug to be FDA approved on the basis of a molecular genetic profile. And that happened in April of 2020 on the basis of a phase 1/2 study called BLC 2001 that looked at an orally administered drug called erdafitinib. It's a pan-FGFR inhibitor. And in that trial, they selected out patients with FGFR2 translocations, FGFR3 translocations, and activating point mutations in FGFR3 using a PCR-based assay. But in those selected patients, response rates of up to 40% were observed, and ultimately, that drug was provided accelerated approval. And so immediately, to be able to identify those patients, you need to be able to do sequencing, right? Now, ultimately, you don't have to do that PCR-based assay. You can use other commercially available next-generation sequencing assays like Foundation or Caris or whatever is available to you, as long as it's CLIA certified. And so once that happened, it became a standard of care. So anyone with chemo-refractory disease in the neoadjuvant setting, so if someone has received neoadjuvant cisplatin-based chemotherapy and has persistent muscle-invasive disease, that patient is a candidate for next-generation sequencing, and it should be approved and covered. And then any patient with newly diagnosed metastatic urothelial cancer is also covered for next-generation sequencing. And I do it early on as the standard of care because it can take up to 4 to 6 weeks to receive those sequencing results back. And once I have it, I know that information is potentially going to be useful in making treatment decisions for that patient.
And does that information influence the algorithm? Let's go back a few months prior to ASCO GU this year and prior to AACR. Does that information, the molecular sequencing information, does that make a difference in the algorithm that one should be using for first-line and later-line therapies for advanced urothelial cancer?
Yeah, that's a great question. So in the first-line setting, it probably doesn't. And right now, based on the current evidence, it should not. But in later lines, it certainly can. And what we find is that after chemotherapy and after immunotherapy, drugs like antibody-drug conjugates and erdafitinib are approved as a standard of care. And so if you have a patient who has an activating FGFR3 mutation, both ADCs and erdafitinib are available treatment options. And depending on the patient's individual situation, their baseline characteristics, some symptoms they may have, some residual toxicities from prior therapies, you may choose one treatment over another. My general view is that patients should have had at least a conversation about all active therapies that are known to benefit patients in the course of treatment of their cancer. But it certainly can affect your treatment algorithm once you know their genomic profile.
That's really helpful, and I'd like to drill down on that a little bit later in our conversation. But let me start by what's happened this year in advanced urothelial cancer. And I wanted to start with the low-hanging fruit, the study on which you had direct involvement, the EB201 study, and specifically cohort 2, on which you reported at ASCO GU. What was that study all about?
So this study is kind of a continuation of kind of better understanding the role for enfortumab vedotin, which is an antibody-drug conjugate, and its role in advanced urothelial cancer. So the drug, it targets a protein that is highly overexpressed on the surface of urothelial cancer cells called Nectin-4. It actually has limited expression on normal urothelium. There is expression on the surface of skin cells, also the cornea of the eye, and some other tissues. Its payload, which is linked to it via a protease cleavable linker, is called monomethyl auristatin E. It is a very, very potent microtubule disrupting agent, similar to vinca alkaloids and taxanes and so forth. And so, it's expected that the toxicity is going to be very much things like neuropathy, which is going to be important later when we talk about toxicity. And its initial development focused on patients who are treatment refractory beyond, kind of all approved standard therapies, including both platinum-based chemotherapy and immunotherapy. And in its initial development, in what was cohort 1 of EV201, it showed a response rate of around 44% and north of 80 to 85% of patients having some decrease in their tumor. So it was a very active drug from its outset, including patients with liver metastases, which is a very, very difficult population to treat. So that was cohort 1. That was the basis for the accelerated approval in December of 2019. And then that same population was tested in the randomized study called EV301 that showed a survival benefit in the third-line setting. Okay, so that sets the stage for the drug. Now, EV201 cohort 2 was kind of an exploratory group. It more specifically focused on a population of patients that were platinum naive, so they'd never received platinum-based chemotherapy, had only received immunotherapy as their treatment for metastatic urothelial cancer, and were ineligible for cisplatin-containing chemotherapy. So the key here is to focus on the fact that these are the patients that are generally most older, they're medically frail, not candidates for more aggressive cytotoxic-based therapy, and in general represent about 50%, sometimes more, of the population that has advanced bladder cancer. Remember, this is a disease of older individuals. A lot of medical problems. Many of these patients are fearful of chemotherapy, heavy former smokers, et cetera. And in this group, we wanted to see, what does the efficacy look like in this patient population? Here, we saw a response rate of 52%, including 20% of patients achieving a complete response. A lot of these patients had liver metastases, very similar to the other groups that we looked at. Very high response rates, north of 40% in that group as well. So this drug is quite active, even in the patients with poor prognostic features, similar to what we saw in the other trials that have looked at enfortumab. And then also duration of response, which is, kind of the other surrogate measure of real clinical benefits. Can you get a response? But then the question is, how long does that last? The median duration of response was longer than 10 months. So it really tells you that in patients who are receiving immunotherapy up front, we hope that it works, but we know that only 30% of those patients respond. This trial shows that this drug can potentially rescue those patients as an option after immunotherapy when we know that platinum-based chemotherapy may not be a safe option for them.
That's fabulous. As long as you bring up the issue of the patients being a little bit older and 50% of them not really being cisplatin eligible, and I know some of these patients with advanced urothelial cancer have upper tract disease and now have only one kidney. A legitimate criticism of clinical trials is that the participants are generally less ill than patients seen in routine clinical practice. Can you tell our listeners anything about the toxicity of enfortumab vedotin in the phase 3 trial, in the phase 2 study that you conducted, or in your personal experience? How rough is this drug?
Yeah, so let me walk you through the experience. And first off, so one thing has been consistent is that the toxicity profile of this drug in the phase 1, phase 2, phase 3 setting has generally been very, very consistent, both in terms of the frequency, severity, and the time of onset of the toxicities. And there are three main things that we worry about. There's hyperglycemia, there's rash, and neuropathy. I'll first focus on this issue of hyperglycemia and rash. They generally occur fairly early in the course of treatment, within the first 1 or 2 cycles. The hyperglycemia part occurs, usually sometimes as an asymptomatic observation. Sometimes it's also accompanied by some acid-base disturbance. In very rare cases, it can be life-threatening. It's not clear what causes it. There's some retrospective kind of look at some of the broader experience across the entire enfortumab vedotin program, and that has linked it toward higher baseline, baseline body mass index, so BMI. I'll talk a little bit about that when I talk about cohort 2, which is where we really saw it. People have postulated this may kind of be linked to kind of a baseline metabolic syndrome, overweight individuals, maybe some hepatic dysfunction. All of this, is more speculation than anything else, but, higher BMI seems to be linked to it. Baseline diabetes mellitus on its own does not appear to be linked to it, but high BMI might be. But the majority of cases are elevated blood sugars. Sometimes it's transient. You can manage them with dose reductions or hypoglycemic agents, et cetera.
As long as you bring up the issue of BMI, and I'm sorry, you were going to say something about rash, but if you could make some comments about whether or not this is something that you've observed clinically since you've been using the drug as well, and whether or not there are any studies that have looked at the mechanism by which BMI might
so
relate
I
to it.
have observed it. So for instance, in cohort 2 of EV201, one of the patients who actually suffered a grade 5 event from a mix of a multifactorial metabolic acidosis, which included kind of a diabetic ketoacidosis, lactic acidosis, acute renal failure, and dialysis dependent. Eventually, the patient died. Was one of my own patients. But this was a very, very overweight individual, but did not have baseline diabetes, and he died unfortunately shortly after his second dose of treatment. Now, that may, imply that baseline high BMI, this patient had a BMI of close to 40. However, there are many other patients who have a very high BMI where we don't see this happen at all, right? And these are exceedingly rare events. So we still do not understand the mechanism of this. And so the rates of this happening are very, very rare. We're talking fractions of a percent. And thus far, we do not understand the entire mechanism yet. And so these cases have been few and far between, thankfully.
Got it. You were going to make a comment about rash. That's another toxicity.
So this is something that we see more often. I'd probably say at least half, maybe 2/3 of patients will have at least some form of a cutaneous toxicity. It presents early on. It can show up much like a sunburn type of rash. And for a lot of patients, it can be itchy. And for most patients, it's quite manageable in the sense that topical steroids, oral antihistamines to treat itch, and much like a lot of other toxicities when it comes to drugs that are inherently cytotoxic in nature, is dose reductions, interruptions, et cetera, are very effective. There are, like all other side effects, case reports of very severe toxicities that can develop, but vast majority are manageable. If anything severe is going to happen, it's going to happen within the first 1 or 2 cycles. And if it's going to be a problem for the patient, that's when you're going to see it. But again, it's a sunburn-like rash, tends to favor the torso, proximal extremities, upper and lower extremities, spares the face. It really doesn't involve the face.
Sounds like you watch your patients pretty closely for that first cycle or 2.
Absolutely. So my practice generally is that, the drug is administered on a 3 weeks on, 1 week off schedule. My practice is that for the first 2 cycles, and certainly before their first response assessment, before they get their scans, I see them with every visit, and it's primarily just to catch anything untoward that's going to happen. After cycle 2, it's unlikely they're going to run into major problems. It's unlikely.
Got it. Thank you.
Yeah.
If we could move off enfortumab vedotin for a second, I think we'll probably come back to it. But as you know, the IM Vigor 130 study was updated at AACR recently.
Yeah.
That was a trial of first-line chemotherapy plus the immune checkpoint inhibitor atezolizumab versus atezo alone versus chemo alone. I actually found the interim results to be a little mixed. So I have to ask you, how are you using the immune checkpoint inhibitors in your practice? Are you using them alone, in combination with chemotherapy? Are you using them as, maintenance therapy in chemo responders? How are you using them?
So I don't combine them with chemotherapy because both Keynote 361 and Vigor 130 were essentially, in my view, negative studies with regard to making a strong argument for combining chemotherapy plus immunotherapy. So the short answer is, if I use immunotherapy, I use it alone. I rarely, if ever, will use PD-L1 expression to help make my treatment decisions. I don't find the PD-L1 expression biomarker really all that clinically useful because it's just woefully inadequate. It's just too inconsistent. And that's just been the case across all the studies that have tried to use it. It's just been inconsistent. A lot of clinical judgment goes into using immunotherapy versus chemo because they're just so fundamentally different in terms of the way the drugs work, safety profiles, and the patients for whom they are appropriate. So it's a mix of the disease kinetics of the disease and the patient, the sites of disease, volume, symptom burden, and the patient's protoplasm and their fitness for chemotherapy. All those factors, which I generally kind of put all together as clinical judgment, those are the main factors that I use.
Got it. Do you choose among the different therapies based on how rapidly you need a response, the anticipated duration, or is it really more related to toxicity and clinical factors
So
like
the
that?
toxicity concerns really only reflect the patients who are very advanced in age, or the patient who I know will not tolerate multi-agent chemotherapy. So that's the bucket that just really gets immunotherapy. Outside of that, if there's a patient who needs a response right away, that patient gets chemotherapy.
Got it. Do histologic variants of transitional cell cancer, those that include squamous plasmacytoid or other elements, do they influence how you prioritize systemic treatments or no?
In somewhat of an indirect sort of way, yes. It's
Okay.
pretty clear that patients who have these other aggressive variants, so maybe less so squamous cell, but certainly plasmacytoid and some patients with micropapillary, for instance, generally present with very aggressive features and have widely metastatic disease that has rapid kinetics and so forth. And so with the variants also, they present with very aggressive features. Ergo, sometimes these patients need chemotherapy. However, it's interesting when I look back at our immunotherapy experience going back to 2014 and 2015, many of my excellent responders to immunotherapy have actually been micropapillary. So there's a lot more nuance to it than just variants get chemo.
Got it. Got it. I know it's important to have quality of life data to kind of contextualize response versus toxicity of any apparently impressive new treatment for cancer. What do we know about patient-reported outcomes and quality of life data with the newer drugs for urothelial cancer? The erdafitinibs and sacituzumab govitecan and enfortumab vedotin. What do we know about patient-reported outcomes? Anything?
So erdafitinib and sacituzumab govitecan have only been approved on the basis of single-arm studies, and they have accelerated approvals. So when you look at quality of life data from any of those, which have not been reported, you really can't interpret them too much because they're not randomized against anything. The data for quality of life for enfortumab have yet to see from the EV301 study, but it will be presented, and there are some manuscripts that are in preparation for this. My sense, though, is that quality of life on these drugs are actually very similar, if not better, because the activity is so robust. Patients' symptoms related to their cancer improve dramatically. And the most significant dose-limiting toxicity tends to be neuropathy with enfortumab, and that develops sometimes on average about 4 months into treatment. And at that point, patients are already in response. So you don't get neuropathy until you've been on the drug long enough. And the only way you've been on drug long enough is if you're responding.
Got it. Got it. I have to ask you this. Do you ever go back to first-line therapy in people who have responded well to first-line chemo? Do you ever dial back and go back to a previous option of therapy, or once that ship has sailed, is it gone and you never use a platinum combination again?
In very rare instances for patients who've had a very long treatment-free interval, and then they relapse sometimes 18 months, 24 months later, I might re-challenge with the same chemotherapy they had in the past. But I'll tell you, it's exceedingly rare for me to see a subsequent response again. This is not ovarian cancer where we have so-called platinum sensitive and platinum resistant recurrences. In bladder cancer, it's just very unusual for us to see patients to respond again to the same chemotherapy. Now, I've seen studies that have looked at, for instance, patients receiving gemcitabine and cisplatin, and then treating with accelerated MVAC, which is also a cisplatin-based regimen, but there are also alternative drugs mixed in there. And so for that reason, I think it's potentially worth re-challenging, but that's a very aggressive regimen to switch to. And so very few patients will ever be candidates for such an approach.
I understand. I was curious, can you give our listeners some insight into what it's been like for you as a specialist in GU oncology to practice during a time when we've experienced such rapid expansion in the options for and the lines of therapy that we have? How's it changed your conversation with patients?
So I share this with all my mentees and fellows that come through our fellowship program, is that I was very fortunate to have entered urologic cancers when I did. I joined my fellowship program in 2009 and I graduated in 2012. And my mentors, when I started, said, you're choosing bladder cancer because nothing has happened in 30 years. And I said, well, I'm not sure if that's such a great thing. And 2 or 3 years later, we have just an absolute explosion of new treatments and new biological insights and trials. And so we as clinicians and as investigators, we are always standing on the shoulders of giants, right? And so I consider myself very fortunate to be able to participate in this process and bringing drugs to market and develop these drugs and have these conversations. And I'll tell you, the conversations I have today with patients are just night and day compared to what I had 6 years ago.
It has to be a lot easier to get up in the morning and walk into clinic than it did a number of years ago, given all the options you can juggle now to patients' benefits.
Absolutely.
Well, Dr. Balar, thank you very much for reflecting on the expansion in options for treatment and the potential for better survival for patients with advanced urothelial cancer. We really appreciate your time speaking with our listeners today.
It's my pleasure. Thanks for having me.
Quite all right. You've been listening to the Blood and Cancer podcast. For those of you who are new to us, please know that when this podcast airs, bullet points of the notes from today's show are going to appear on the webpage, mdedge.com/hematology-oncology. Again, that's mdedge.com/hematology-oncology. The notes can really be a helpful refresher of the insights that Dr. Balar provided for us today. I'm Dr. Alan Lyss. Please join us again next week, and thanks for listening.
Blood and Cancer is produced by MDedge. Our editor is Jen Smith. All MDedge podcasts are produced by Executive Editor Kathy Skarbeck, and I'm your host, Dr. David Henry.